Hello everyone and welcome to our module on breast tissue. Let's start by talking about the structure and function of the female breast. The breast is a glandular structure that produces milk for the baby, and it's made up of about 15 to 20 lobes. If you look at this picture on the right side of the screen here, these large bumpy structures are the lobes of the breast. Each of the little bumps in the lobe is a lobule, so there are multiple lobules in each lobe and there are multiple lobes in the breast. Each lobe is connected to a duct which can drain milk to the nipple, and then the entire structure is surrounded by connective tissue called stroma and also fat. And here's a zoomed in picture just to make this more clear. These are the lobes and the lobules. Each lobe is connected to a duct which drains milk to the nipple. The areola is the tissue surrounding the nipple. There's fat and stroma surrounding the lobes and lobules. And you can see these little dilatations of the ducts right before the nipple. Those are called the lactiferous sinuses. In another video, I'm going to discuss breast cancer, and in order to understand breast cancer, you must understand the concept of the terminal duct lobular unit, because this is the small structure in the breast from which many breast cancers arise. So basically, each lobule in the breast, as shown here with this blue circle in my cartoon, is connected to a duct called a terminal duct, which then drains into a larger duct, which then takes milk out to the nipple. So each terminal duct and lobule is called a terminal duct lobular unit, and this is what creates milk for the baby. You can break down this unit into a couple of different structures. The extralobular terminal duct is this portion of the duct here that's outside the lobule. That's why it's called extralobular. Within the duct, there are a branching system of intralobular terminal ducts that connect to each of these little clusters of epithelial cells shown as red dots, which are called acini. So what you've got is these clusters of sacs, these acini, which are making milk. It's going into the branching intralobular terminal duct system and then into the terminal duct for each lobule. And this entire structure is called a terminal duct lobular unit. So basically the breast is made up of thousands of little units where you've got a terminal duct and then it branches into a number of smaller ducts. And each of those smaller ducts goes to a collection of cells that forms a sac called an acini, and the milk goes out of the sac into the branching ducts and out into the terminal duct. This entire structure, all the ducts and the acini, is covered by breast epithelium. This lines the surface of the ducts and lobules, and one thing that you should know that's special about breast epithelium is that it contains two layers over a basement membrane, not a single layer like most epithelial layers. The innermost layer is called the luminal epithelial cells. These are the cells that secrete milk, but on the outside of those are myoepithelial cells. These are contractile cells that respond to oxytocin. So basically, if this is the basement membrane of a duct, what we have are a series of myoepithelial cells on top of the basement membrane, and then on top of those, we have luminal epithelial cells, which are the cells that secrete milk. These line the ducts, and they also line those acini inside of the lobules. Breast tissue develops from embryonic structures called the milk lines. These are two thickenings of ectoderm that form the breasts and nipples. And you know that ectoderm leads to development of the skin, so it makes sense that it would also lead to development of the breasts, which are attached to the skin. The milk lines run down both sides of the embryo from the axilla to groin, as shown in this picture here. They form structures called the mammary ridges, which disappear during development except for the breast tissue. And sometimes people are born with an extra nipple, which is called polythelia, and those extra nipples are usually found somewhere along the milk lines. They are portions of that ectoderm that did not completely disappear during development. Breast tissue is hormone sensitive, and it's high yield to understand the different hormones that can affect the breast tissue. So estrogens have major effects on the ducts. At puberty, estrogen in the female leads to an increase in breast size by causing growth of the ducts. And in the menstrual cycle, many women experience cyclic increases in breast size, which can lead to breast tenderness, and this is related to estrogen. And also during pregnancy, there are lots of estrogens in the female body, and this leads to an increase in breast size during pregnancy. Progesterone mostly acts on the lobules, and it results in growth in lobules, and this is especially important during pregnancy because it prepares the breast to make milk for the baby after delivery. And then prolactin can also affect the breast. Levels of prolactin are increased in pregnancy, and this also contributes with the increase in breast size seen in women who are pregnant. So let's talk about breast tissue during pregnancy. There's growth of breast tissue in pregnancy, and this is driven by hormones, as we just discussed. It's mostly driven by estrogens, progesterone, and prolactin, although there may be some effect of HCG as well. Importantly, however, in pregnancy, there's no significant milk formation, and this should make sense to you. It wouldn't be smart for the body to waste calories and energy producing milk for a baby that has not yet been born. It makes more sense to divert those calories to the baby and then only produce milk after the baby has been born. So during pregnancy, progesterone and estrogens inhibit milk formation. They allow the breast tissue to grow in size, but they inhibit it from producing milk. After delivery, there's a fall in hormone levels, and this is when milk production begins to occur. And at this point, the breasts have grown in size, so they're ready to produce large quantities of milk for the baby that has just been born. So during pregnancy, the breast tissue grows in size, and after delivery, milk production begins. But the mother will not continue to lactate unless she breastfeeds her baby. Maintenance of lactation requires removal of milk and nipple stimulation by the baby. These things trigger prolactin release from the anterior pituitary and also oxytocin release from the posterior pituitary, and these two hormones keep the breast tissue producing milk. If the mother does not begin to breastfeed her baby and there's an absence of milk removal, involution of breast tissue will occur. So in the hospital, after babies are delivered, nurses and pediatricians will encourage mothers to start breastfeeding right away, because if they don't do it, they will never be able to breastfeed their baby later. Also, one thing you should know is that when mothers breastfeed, the prolactin release that occurs inhibits ovulation. This will keep the mother from becoming pregnant again during the time when she is breastfeeding. The main sugar that's found in breast milk is lactose, but what you should be aware of, especially for step 1 of your boards, is that breast milk contains lots of antimicrobial components, and these are very helpful to the baby. They prevent the baby from developing infections during the newborn period. So first of all, there's lots of antibodies, especially IgA. This leads to passive immunization. Basically, the mother's IgA is being passed into the gut of the baby so that the baby has immunization against GI bacteria. There are also macrophages and lymphocytes. An important structure in breast milk is lactoferrin. This is a large globular glycoprotein that has lots of antimicrobial activity. It's got iron in it, that's why it's called ferrin. It's similar in structure to transferrin, which you may know transports iron in the body. There are also enzymes called lysozymes in breast milk, and these break down bacterial cell walls. So all of these things help protect the baby from infection. This is another reason why pediatricians encourage mothers to breastfeed. With that in mind, let's talk about the benefits of breastfeeding for the child. First of all, babies who are breastfed have a lower risk of infections, especially GI and pulmonary infections, for all the reasons we just discussed on the last slide. In addition, there are some data suggesting long-term benefits when babies are breastfed. Some studies show reduced incidence of allergies, diabetes, and obesities among children who were breastfed as babies. There are also breastfeeding benefits to the mother. Mothers who breastfeed have a lower risk of breast and ovarian cancer. Breast and ovarian cancer is driven by ovulation, and as I just told you, prolactin inhibits ovulation, so this lowers the mother's risk of developing these types of cancers. There's some evidence that mothers who breastfeed have a lower risk of cardiovascular disease. There's a faster recovery from childbirth. Mothers who breastfeed tend to be less stressed out, and they bond better with their baby. And then another important thing for many new mothers is enhanced weight loss. Basically, you're giving away a few hundred calories a day to the baby, and mothers who have gained weight during pregnancy often like this because it helps them to lose that weight they gained when they were pregnant. And then, as I said before, when women breastfeed, because of prolactin, there's longer anovulation, in other words, a longer period of time before the woman begins menstruating again. This is often nice because she doesn't have periods every month, and it also prevents a pregnancy in the newborn period. I'll finish this video by talking about a couple of abnormalities of breast tissue. The first one is galactorrhea. This is production of milk that occurs outside of lactation. So a common complaint of women and sometimes men in clinic is to complain of nipple discharge. This is galactorrhea. Most of the causes of galactorrhea are related to prolactin. As I just told you, prolactin release from the anterior pituitary leads to milk production. So anything that increases prolactin levels in the body can lead to galactorrhea. Another thing you need to remember is that prolactin release by the pituitary is inhibited by dopamine from the hypothalamus. So anything that is a dopamine antagonist can lead to more prolactin, and that can lead to milk production. So with that in mind, listed on the screen are some common causes of galactorrhea. The first one is chronic nipple stimulation. This is called neurogenic galactorrhea. As we just discussed, during pregnancy and in the newborn period, stimulation of the nipple leads to prolactin release. So stimulation outside of the newborn period can also lead to prolactin release. So a classic example is a poorly fitting bra that irritates the nipples. That leads to prolactin release and galactorrhea. Another classic cause of galactorrhea is a prolactinoma. This is a pituitary tumor, and nipple discharge is a classic sign of someone with a prolactinoma. I talk about this disorder in the endocrinology section in the video on the pituitary gland. And then finally, there are a number of drugs that can cause galactorrhea. The classic one is Haldol, which is a typical antipsychotic. It has dopamine blocking properties, and for that reason, it leads to higher levels of prolactin and can cause galactorrhea. Next, let's talk about gynecomastia, which is breast development in males. This is a picture of gynecomastia shown on the screen here. Sometimes this is physiologic, meaning it is not due to a pathologic underlying disease. We'll talk more about that in a minute. And in addition, gynecomastia often occurs in association with galactorrhea. You can imagine that when the breast tissue grows large, like shown on the screen here, that some milk production can also occur. To understand gynecomastia, you need to remember that males have lots of androgens, but they also have some estrogens. And under normal circumstances, the androgen levels are much higher than the estrogen levels. So anytime something either knocks down androgen levels or increases estrogen levels, this can disrupt this balance, and that's what leads to gynecomastia. So with that in mind, shown on the screen are some physiologic causes of gynecomastia. This problem is common in newborn male babies. This is because there's placental transfer of estrogens from the mother. This resolves with time once that placental transfer of estrogens has been removed. This also often occurs at puberties in males. So at puberty, males begin producing lots of androgens, but some of those androgens are converted to estrogens in the periphery, especially by fatty tissue. And sometimes in males at puberty, initially the balance is off, such that there are more estrogen effects, and this can lead to a transient gynecomastia. And then finally, it's common in older men, especially men over 50, like this guy shown on the screen here. That's because as men age, they lose testosterone production from the testes, and they often have more fatty tissue, which converts androgens to estrogens. As a result, they get an imbalance with more estrogen effects, and they get some gynecomastia. On this slide, I've listed a number of pathologic causes of gynecomastia. First of all, cirrhosis. People with cirrhosis are unable to normally metabolize estrogens, so they have increased estrogen effects, and in males, this can lead to gynecomastia. In Klinefelter syndrome, males are born with an extra X chromosome. This is a classic cause of male hypogonadism. They have decreased testosterone production, and that can lead to gynecomastia. And then finally, there are a number of classic drugs that can cause gynecomastia as a side effect. All of these medications have anti-androgen effects. So spironolactone, which is a diuretic, and cimetidine, which is a histamine blocker. Both of these drugs have anti-androgen effects. Ketoconazole is an antifungal agent. It can block the effects of androgens. It can also block production of androgens. So for both of these reasons, ketoconazole can lead to gynecomastia. And that concludes our video on breast tissue.